So this is about a 26-year-old female with KPS 90. She presented to us with right nasal blockage and progressive right eye proptosis for 2 months. She initially presented to the ENT clinic. The ENT surgeons got her MRI brain with contrast. So that was done outside AKUH on 27th of October 2024, which showed a contrast-enhancing lesion extending from the right nasal cavity up to the right orbit to the right parasagittal region. She underwent endoscopic biopsy of the lesion on 12th of November 2024. Histopathology showed olfactory neuroblastoma. So she then presented to us. We did an open craniofacial resection of the lesion on 10th of December 2024. Post-op MRI brain with contrast was done at AKUH on 11th of December 2024, which showed near complete resection. One more thing, she also got a PET scan done, and PET scan showed suspicion of pulmonary metastasis. So then we got a CT guided biopsy done of those pulmonary lesions, which is awaited.
तो अभी तक हमारे पास इसकी बायोप्सी हिस्टोपैथ नहीं आया
सर हिस्टोपैथ आ गया है सर जो ऑल्फैक्टरी न्यूरोब्लास्टोमा था हमारे पास लास्ट हिस्टोपैथ में वही अभी भी आया है
So it's olfactory neuroblastoma. Okay.
Yes.
So we have Dr. Shumaila with us, so she can tell us more about the radiology.
जी अस्सलाम वालेकुम.
Assalamualaikum.
So if we start with the first slide, मैंने अपने पास क्योंकि अलग से डाउनलोड करके भी खोली हुई slides. So first set of images is T2 weighted axial images, and there we can appreciate that there's something filling the right nasal cavity and causing mild proptosis. Medial wall of orbit is also showing some remodeling, and there is some intracranial component which is projected in the region of gyrus rectus on the right of midline and parasagittal truncation. And all of these are returning T2 hyperintense signals. Other than that, there is no abnormal signal intensity area within the brain parenchyma or nasal cavity. So if we go to the next set of slides, these are T1 weighted post-contrast images. And here we can appreciate that this area is, since I haven't seen the plain T1, so I can't, say that how much it is enhancing, but there is some abnormal signal intensity area, the same area is redemonstrated in these images. Probably I think ये जो first वाले set of images हैं ये मुझे plain लग रहे हैं, T1 contrast नहीं लग रहे, जिसपे लिखा हुआ है pre-op MRI brain with contrast. इसमें कोई enhancing component नहीं है as such. अगर आप if you look at the part of the lesion which was close to gyrus rectus, so I cannot appreciate any enhancement. But if I go to the next set of images, I can see that there is some enhancement. So probably those were pre-contrast, which are labeled as post-contrast, the second set of slides. The third one is post-contrast, and I can appreciate that there is enhancement, which is quite significant. And the portion which is projecting in the cranial cavity is showing intense enhancement. The portion which is in the nasal cavity is showing heterogeneous kind of enhancement. And if we go to the next set of slides in which we have sagittal dedicated images from the orbits and nasal cavity, we can appreciate that this lesion is showing connection. It is passing through if you look at the first image in the second row, you can appreciate that there is a connection between the intracranial and intranasal component. So this is something which is probably going through the olfactory groove, because this is the location of olfactory groove. And it has an intracranial as well as an intranasal component. In the coronal post-contrast images, the next set of images, we can appreciate that this component is showing extension in the orbital cavity, and it is reaching up to the right optic nerve. I cannot appreciate the right medial rectus. Part of right superior and inferior rectus, they also appear to be infiltrated by this lesion. So since it is in the line of olfactory epithelium and olfactory groove, and it is showing extension from right nasal cavity to the brain, so my first differential will be definitely esthesioneuroblastoma or olfactory neuroblastoma. And then we have few, differentials like meningioma, which is lying on the olfactory groove, but it is not typically fulfilling that criteria, but that would be one of my differentials. The second differential can be some kind of a nasopharyngeal carcinoma, but she's a 28 years old 28, 29 years old female, so that is not not the age for nasopharyngeal carcinoma. If I consider nasopharyngeal angiofibroma, so it is exclusively in young teenager males, so that also, that also is excluded from my differentials. It is not a typical place for chordoma or something like that. So my first differential is olfactory neuroblastoma or esthesioneuroblastoma, and the second is an olfactory groove meningioma.
Okay. Thank you, Dr. Shumaila.
You're welcome.
And what about the post-op? Will you call it gross total, or can see some residual?
So if you go through the post-op images, especially the sagittal images, which are, I think, the fourth slide in a row. So there appears to be some residual lesion in the line of, this the surgical tract. And the thing is that the olfactory neuroblastomas, if we stage them, they're staged as A to D. So in stages C and D, there is a possibility of lesion which is beyond this olfactory epithelium, and distant metastases are, part of this disease spectrum. They can present with distant metastasis. So I'm not sure what we found in the lungs was a distant metastatic deposit. Definitely histopathology will confirm that, but they tend to metastasize in advanced stages. I think there is some residual, but I have to
Okay.
I have to, critically go through the DICOM images. Saying on this is that there is some component which appears to be enhancing, but still I don't have that side by side, the pre and post contrast. So I mean, it's difficult to say.
Okay. Thank you.
Thank you.
So, Fatma. So what was the KPS? Sorry, I forgot the KPS, Fatma. Patient ka?
Say KPS 100.
Acha, theek. So, Dr. Mazhar, what will be your recommendation?
Actually, as the radiologist or the doctor who was presenting, it said that there are lesion in the lungs that has been biopsied, but the report is not back. If that's metastasis, then this patient would need upfront chemotherapy, should be referred to the medical oncologist. And patient definitely, if there were no lung metastasis, then radiation is definitely indicated in this case, plus chemotherapy as well. So अब तो अगर मेटास्टेसिस लंग में आ गए तो it becomes sort of a palliative case. उसमें फिर हम chemo start करेंगे, and after 3 or 4 cycles of chemo, restage the patient, and if the patient is in remission or the lesions have responded, then one can consider radiation to the local area at the end.
Okay. Okay, thank you. Dr. Asim yes, Dr. Asim is with us. Dr. Asim, would you like to add something regarding this management?
I think, Assalamu alaikum all. I totally agree with the Dr. Mazhar. For localized disease, esthesioneuroblastoma or olfactory neuroblastoma, the main modalities is the surgery, and followed by focal radiation therapy to that area in order to provide a local control. However, in advanced cases where actually there is a chances to actually metastasize, or in cases of distant metastasis, definitely the role of chemotherapy is there to start with. So I totally agree with the as discussed by Dr. Mazhar, that if it turn out negative for regarding the lung nodule, then definitely this patient require actually the adjuvant radiation therapy, plus also consideration because because it is a Kaddish 4 most probably, because esthesioneuroblastoma classification is known as Kaddish on the basis of is known as Kaddish staging system. So most probably it is Kaddish 4 because has a nasal component as well as ventricular component as well. So it is Kaddish 4. So in that situation, this patient require actually the adjuvant radiation therapy, provided the lung nodule turn out to be negative on biopsy.
Okay. Thank you, sir. So any other questions from the panel?
So one of the important thing is, because this area is very notorious for where it's very critically from surgical perspective as well. So if you could or some of the other surgical colleagues comment on the surgical aspect of dealing with this esthesioneuroblastoma, it would be nice for us to actually learn.
So the question is, as surgical challenges or surgery in this
Yeah,
particular patient?
yeah, surgical challenges.
Yeah, I think the most important component when we are planning is how aggressive the disease is, and with of course, we go with that mindset of gross total resection, but again, you have to always balance that gross total versus, you can get the oncology control, but if the morbidity is quite high. So I think so it depends on that as well. And sometimes we also need multidisciplinary approach. It's not only the neurosurgeon. If it's, sometimes we need ENT colleagues also with us, and ophthalmology also, if orbit is involved and all these things. So sometimes it's really challenging to take it all out, but it depends the extent of the disease.
Thank you.
Any
Anyone
other
else?
comments from others? We have with us different neurosurgeons also. Assalamu alaikum, Dr. Akil. Welcome to Tumor Board. Okay, if no more questions, then we can move to the next case.
So one thing, Dr. Hassan, what about the vision of this patient? Is it intact, or because analysis is also averting
Yes.
the right orbit as well?
Sir, the
Fatima?
vision is intact.
Okay, vision is intact.
Assalamu alaikum, Hassan. How was this tumor resected? Did you guys do a transcranial or a combined approach?
Fatma,
Sir, it was the combined approach. Plastic surgery, ENT, and neurosurgery did it together.
So was there a craniotomy and an endoscopic endonasal? Is that how
No,
it
sir,
was
it
done?
was a no,
on
sir. It was just a craniotomy, and basically हमने extend किया था to lateral rhinotomy भी की थी इसकी.
Okay.
so only transcranial.
Yes.
Okay. ठीक. All right. So let's move to the second case. Alicia, are you with us? Can you please present? Okay. Do we have any other resident who can present this case? I think Alicia mute है. Zainab or Fatma, if
Sir,
you.
I can present. मैं
Okay,
कर
fine.
देती हूँ.
Gigi, please.
So he's a 33-year-old male with KPS 90, status post right irional craniotomy and resection of sellar and suprasellar lesion. That was done on 5th of December 2017. Post-op MRI showed significant residual disease. Histopathology showed adamantinomatous craniopharyngioma. Then the patient got cyberknife till in March 2018. He developed left
Sorry,
hemiparesis and facial weakness in 2019. MRI brain was
please
then
come
done
back.
in 2021, which showed reduction in size of the tumor. Now with multiple cranial nerve palsies, MRI done on 18th of December 2024 shows mild progression of the lesion.
Dr. Shumaila, over to you, ma'am.
Ji. So if we start with the initial images, the first set of images which are from 2nd August 2017. So these are axial T2 weighted images, and we can appreciate that there is a heterogeneous signal intensity area in the midline posterior to the optic chiasma. It has a large hypointense component as well, which is lying in the midline in the line of third ventricle probably, or inferior to third ventricle, and then there is some component which is extending in the right cavernous sinus. The temporal horns, they appear to be slightly plump, so probably this is causing some kind of hydrocephalus, but I cannot appreciate because these are only limited cuts. If we go to the sagittal images, the next set of images, we can see that there's a midline lesion which is in the cellar and supracellular location, and it is causing significant compression on the midbrain. Posteriorly, superiorly, it is displacing the third ventricle, and anteriorly, it is extending into the sphenoid sinuses. I cannot appreciate the clivus separately. I don't know because it is because of the limited cuts maybe, but the clivus is not visible to me in any of the images which are pre-op, although the third image is in midline because I can see whole of the odontoid pec, so it's a midline image, but the clivus is not clearly visible. So it is causing, a significant compression, predominantly on midbrain. It has an enhancing and a non-enhancing component. The component which was hypointense on T2 is not showing much of the enhancement on sagittal images as well. So in the next images, we can again appreciate that there's a large lesion. It is lifting the third ventricle upwards. It is causing compression, mass effect. It is extending into the right right cavernous sinus, abutting the right medial temporal pole of the brain, and heterogeneous signals, heterogeneous enhancement, large mass. Optic chiasma is not seen separately in any of the provided images. So since I know that this is a craniopharyngioma, so definitely I would call it that because I know histopathologically, but if I would have seen this patient unbiased without knowing the histopath, I would have kept chordoma as one of the differentials. And then we go to the, next post-op, pre-CyberKnife images from November 17. And again, we can, appreciate that there is still a large residual lesion with heterogeneous enhancement. The supracellular component is still there, the component which was lifting the third ventricle or projecting. Along the floor of the third ventricle, there is a right paracavernous component, and there's still a large residual lesion left with heterogeneous enhancement. If we go to the post-op sagittal and coronal images, again, there is a large, especially on the coronal, you can appreciate that there is large residual lesion. It, the size does not appear to be very much regressed. There still appears to be a large residual leftover lesion to me. So the same things are, redemonstrated on axial post-op November 2017 slide. Then we have post-CyberKnife December 2021 images, and here we can see these are almost more or less similar, but seems that there are some internal areas of necrosis because probably you can't appreciate much on these images, but if you go to the last slide in which you have tried to compare the three images side by side from different dates in which you have shown comparison between 1st November 17, 12, 12, 21 and 18, 12, 24. So here you can appreciate a little better that on post-contrast sagittal T1 weighted images, the lesion was largest, obviously in the first provided image, but then the enhancing component has decreased, although there is still mass effect and still residual mass, but the enhancement pattern has gradually decreased over a span of 6 to 7 years. Probably because of radiotherapy, there are multiple internal non-enhancing areas in the last provided images from December 24. And if you go back to the slides in which you have written the most recent MRI 18, 12, 24, and you have shown some T2 weighted axial images. So here we can see that the component on is causing mass effect on pons, and probably the origin of multiple cranial nerves is disturbed because of this compression and mass effect. As you mentioned in the history that there are multiple cranial nerve involvements. So it's because of the involvement of right cavernous sinus and then the mass effect on the brainstem from where most of the cranial nerves are exiting.
Right. Thank you. Okay. Dr. Mazhar, what will be your recommendation in this scenarios? Like
Now, I think this because this patient had a surgery in 2017 and had in March 2017, I think the patient had cyber knife treatment. So I'm not sure how much dose was given through CyberKnife at that stage. It's almost now 5, 6 years. So there is a recurrence. If resurgery is possible, that should be an option.
Right.
If surgery is not possible, then patient would need palliative radiotherapy plus minus chemotherapy palliative. So because radical radiation cannot be offered because of the previous, and it's a sensitive site, वहाँ पे optic asthma वगैरह की tolerance dose, if not more than 50 gray, can be given. Otherwise, patient can get blind. So surgery would be my first choice if possible. If not, then palliative radiotherapy just to palliate the patient.
Okay. Dr. Asim, sir.
So what's the current clinical symptoms of patient?
So multiple cranial nerves are involved according to the case, and I think cranial palsies.
Mhm. And if we look at, because this is a comparison scan that is exactly shown on the screen right now. So
Ji.
if we look at the scan, then the most recent scan shows almost the similar size. I don't think so there is any as such there is progression. So the issue is that this patient is already exposed to the radiation therapy previously. So and looking at the relationship of this lesion with the different critical structure, including brainstem itself, the vasculature surrounding the tumor, as well as the normal structures, as well as the relationship with the optic chiasm and the nerves. So I don't think so that the further radiation therapy is a very vital or option, because it may actually lead to the further deterioration of what the patient already has. Um, I totally agree. If the surgical excision is possible, then one can actually looking towards the surgery to actually to further develop it. If and the other thing is that we need to, if it is not possible, then one of the options is just to actually provide the best supportive care or the symptomatic treatment. What that is actually the unfortunately that is one of the thing, because looking at all the scans and the previous history, that would be the one out of the option.
So if we can go back, do something surgically, then you're recommending surgery like Dr. Mazhar, otherwise palliative care, right?
Yeah, but because the definitely, because not there is a limitation as mentioned by Dr. Mazhar also, that we have a limitation of radiation. Whatever dose actually, because the almost the extent of the tumor is almost somehow is similar that we have seen in 2017. So considering this relationship with the surrounding structure, I don't think so. We will provide a meaningful dose, provided that this patient is already exposed to the previous radiation as well. And so I don't think so radiation is a vital option. Regarding the systemic treatment, because I'm not an expert in this condition, so we can ask my medical oncology if it can provide some help in this type of situation. Though chronopharyngioma itself traditionally is treated by this surgery or radiation therapy.
Right.
There's very limited role of systemic treatment in the management of craniopharyngioma. But because of the situation, one can actually concern because
Okay.
I don't know whether it has an impact or not.
Dr. Mazhar, do you think is there any role of chemotherapy in such patients?
There is a data that chemotherapy or immunotherapy can be tried, but I think any specialist person who deals with such tumors
Yeah.
would be in a better position to answer this question. But definitely, it has been mentioned that uh, immunotherapy and chemotherapy can be offered. But in this case, I personally feel that if debulking can be done, that would be one thing. And if that's not possible, then just very limited small field just to cover that tumor, 20 gray in 5 fraction, which the palliative dose can be given just to relieve the patient's symptom and should be given referred to palliative services.
Okay. Thank you.